विनय सर.
मानसी 1 मिनिटाचा टाइम देऊयात सगळ्यांना.
हो 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 हो
आणि युट्यूबची लिंक ग्रुपवरती टाकते.
हो हो. सर जॉईन झालेत ना?
हॅलो.
हा सर.
संपला का लेक्चर?
नाही
जॉईंट होत म्हणजे आवाज येत नाही ना?
तर we will wait for 2 minutes. There are people who are joining. थोडी मीटिंग अब्रप्टली एंड झाली.
ओके मॅडम.
म्यूट करा प्लीज मृणालिनी. डॉक्टर मृणालिनी.
या आय विल.
सर तुम्ही बाहेर पडा याच्यातून. एक मिनिट लगेच नको बाहेर पडू. सरांना जॉईन करता येत नाहीये कारण 100 ची कॅपॅसिटी झाली आता. तर हॅलो.
हा बोल.
येस सर. मानसी, आय विल रिक्वेस्ट 1-2 जणांना कुणाला बाहेर पडता येईल सो दॅट विनय सर जॉईन करू शकतील. कोणी 1-2 जण बाहेर पडू शकतात का? आय एम शेअरिंग युट्यूब लिंक ऑन व्हेरियस ग्रुप्स.
मॅम मी पडू का?
प्रतीक तुम्ही का?
मॅडम मी लेफ्ट होतोय.
ओके येस प्लीज. मी लिंक पाठवतेय ग्रुप्स वरती.
थँक्यू सो मच मुकेश. डॉक्टर मुकेश थँक्यू सो मच.
या
विनय सर जॉईन झाले.
हा येस
सर सॉरी फॉर इनकन्व्हिनियन्स सर.
No, it's okay. I don't know from where I kept on talking and then I did not realize that it had.
एक्झिमा नव्हता सर. त्याच्या मागची स्लाइड आहे. एक्झिमा पर्यंत नव्हतं आलो सर. त्याच्या आधीची स्लाइड घ्या.
एक सेकंद.
हा येस सर. इथपर्यंत आला होता.
आपण ट्रीटमेंट च्या बद्दल बोलतो का? पिट्रियासिस वर्सिकुलर.
Yes, sir.
ओके.
हो.
ही नाही पाहिली.
हा. प्लीज म्यूट करा. जोशुआ.
Hello.
Yes sir.
Is Rupa calling me or something because I got a call?
नसेल सर मगाशी.
मला परत येतोय तिचा कॉल.
येस सर प्लीज टेक इट देन.
एक सेकंद ना.
नाही सर हे बाय चान्स चुकून लागला जातोय. आय एम नॉट कॉलिंग रादर आय एम गेटिंग युअर कॉल असं होतंय.
नाही ओके.
काहीतरी कन्फ्युजन. हा
ओके चलो लेट्स स्टार्ट फ्रॉम हियर. सो
सर वर्सिकलरची ट्रीटमेंट परत सांगा म्हणून आलेत मेसेज जरा 2-3.
ओके.
येस सर. थँक्यू सर.
So the treatment of pityriasis versicolor is topical azoles mainly. People do use terbinafine, but it is not as effective. We have been using for a very long time selenium sulfide. the shampoo, Selsun shampoo or something like that. But that is to be applied for a very short contact. We can use topical azoles for a long time, overnight, etc. But selenium sulfide is to be applied very short contact, because otherwise it irritates. So usually 10 to 15 minutes before bath, you apply selenium sulfide on the areas affected by pityriasis versicolor. And the oral treatment, here we have said that we can give antifungals for 1 to 3 days. So fluconazole is one of the best drugs, because this is a yeast-like organism, budding, and so budding yeast-like. So fluconazole is a good drug. Ketoconazole also can be used. Itraconazole can be used, but fluconazole is probably the best drug. And the dose would be about 400 milligrams once a week for a prolonged time. Also helps treating the pityriasis versicolor. I don't know whether you heard, but post-inflammatory hypopigmentation of pityriasis versicolor is going to last for a very long time, and we need not all the time keep on treating the post-inflammatory hypopigmentation, considering that or thinking that pityriasis versicolor is not gone. So if there is no scaling, we can safely stop the treatment. We can ask the patient to take a bit of sun rays on that, which helps in repigmentation. So what do you see here? I think we will run through. You can have a look and write down your own notes, but for want of time, I think we should rush through, because it is already 4 o'clock. This on the neck and as well as in the flexures, we see scaly lesions. On the neck, we also see that the skin folds are exaggerated. There is hyperpigmentation. This is called as lichenification of the skin. On the right hand side, what we see is the flexural lesions with cracks, scaling, erythematous papules, and excoriations. This is eczematous lesion. We see fingers with erythema and scaling. There is exaggerated erythema on the palms, and these are usually because of some kind of a contact. Most probably this would be hand eczema or housewives eczema because of detergents. This could be because of workers who are masons who come in contact a lot with cement, etc. These are oval lesions, annular lesions. These are disseminated lesions sometimes. They are subacute or acute eczema-like lesions. There would be oozing on these lesions, scale crusts would be there, and there would be severe itching in these patients. This is called as discoid or nummular eczema. Here is another case of eczema on the hands. Erythema, scaling, tiny vesicles. This is typical, a childhood eczema. This is a very typical childhood eczema where there is erythematous scaly lesions on the cheeks. This is also seen in the folds of the neck. It would be on the extensor aspects of legs and arms, forearms in the childhood. These children actually need less of soap, lot of emollients on the body while the skin is wet. A typical thing in our homes, usually with the children, is that they are massaged with oil and then are given a very hot bath to remove the oil. This is detrimental to children who are having atopic dermatitis. What we tell them is, don't apply oil before bath, use least of soap, or we have this Sindate bars or soaps with a lot of emollients, and then while the skin is wet, apply any oil or moisturizer or anything on the skin, because this is a very dry skin. We can use topical non-potent or very mild steroids to tide over the crisis, because sometimes they can be very severely itchy lesions and the child is very much disturbed because of the pruritus. See that the children are wearing only hosiery type cotton clothes. They don't come in contacts with wool, etc., because the skin is extremely irritable and they start scratching as soon as. So their blankets, etc., should be very soft and cotton clothes to be advised. This atopic dermatitis, when goes into childhood stage, adolescent stage, and then adult stage, usually becomes a subacute or chronic eczema-like thing with lot of lichenification, thickening of the skin, and it is very difficult to treat. and may require cyclosporin, may require azathioprine, may require the drug which I just now mentioned, tofacitinib. There are some biologics which I mentioned in terms of in case of psoriasis, which are now available, like omalizumab, etc. And all these have to be taken into consideration, with sometimes treatment with short bursts of steroids also required in some cases. But we will try to avoid systemic steroids as much as possible. So this is eczema. It's caused by dry, reddened skin that itches or burns. The severity varies from person to person. Intense itching is generally the first symptom in most patients with eczema. Sometimes it may lead to blisters and oozing lesions, but eczema can also result in dry and scaly skin. Repeated scratching may lead to lichenification. So we have seen atopic eczema. There is varicose eczema, we know, on the lower limbs. Usually, one of the differentiating factors from other leg eczemas is varicose eczema or stasis dermatitis always happens on the medial side, near the ankle. Okay, and the other eczemas would be on the outer side, but there can be severe varicose eczemas also. We have talked about discoid eczema. And there are two types of the common things are irritant dermatitis and contact dermatitis. Irritant dermatitis, as I explained, can happen with cement, etc., or people working with acids, because the differentiating feature of irritant dermatitis, acute irritant would be there would be something like a burn. But the pathogenesis is that if a substance is going to cause irritation, it would cause irritation to most of the people. Whereas contact allergic dermatitis would be seen only in a few people, with the same thing being applied by many people or used by many people, because that's a type 4 sensitization. It's a contact dermatitis. It's a latent allergy that happens in the skin. Here we see allergy to the ring. So dermatitis means inflammation of the skin. The skin is itchy, inflamed, causing redness, swelling, cracking, weeping, crusting, and scaling. Dry is very common and sometimes a typical rash. And it is usually occupationally related, or we can find out the substances which are causing the allergy. Now, in case of treatment, one of the things which we say that dry skin or dry eczema is always to be treated with ointments. That is the oilier kind of things. Whereas oozing things are always to be treated with creams and lotions because they are more watery. And so when we are having an acute eczema or subacute eczema, we can always give normal saline soaks on that or warm water soaks on that, see that the crusts are removed, and use creams. Whereas dry scaly skin, we have to use ointments or oily things, and we can apply emollients on top of that. Here we see a eczematous band around the waistline. This is hand eczema. We can see vesicles on the hands. Nickel is one of the commonest kind of metal that causes contact allergic dermatitis, and we all should know that because this is what we call as the nakli dagine, artificial ornaments, which contain a lot of nickel. And it is one of the commonest things. We can see that near the belts, in the earrings, or with the various ornaments, necklaces, jodvi payatli, they may sometimes contain nickel. Some people have the habit of putting coins in their pant pockets, and then they may have an allergy on the thighs. So nickel is one of the commonest thing. What we can do to prove that not only nickel, but is a patch test. So we apply different allergens on the skin under occlusion and observe them after 48 hours, and we can find out what thing is causing the allergy. What do you see, and what is it called? Do you know the name of this? This is called dermographism. You can write on the skin, dermographism. So in people who have this dermographism or some kind of arterial rashes, when we scratch or we draw lines with pressure, we will soon get urticarial wheals at that site. This is called dermographism, and this is a part of urticaria. Now, urticaria is again a very common condition. It is divided into two types. One is acute urticaria, the other one is chronic urticaria. Acute urticaria, we are usually able to find out the cause because it happens. Person would come and say की काल मी काय बाबा गवारीची भाजी खाल्ली आणि आज मला त्रास झाला, काल मी मासे खाल्ले मला त्रास झाला, that kind of a thing. Or I went out in the sun and I got this allergy. What the characteristic actually lesions are wheals, urticarial wheals, and they are evanescent erythematous lesions. They come, they change the place, change the shape, disappear, and keep on going from place to place. They can be annular, they can be extensive. In case of acute urticaria, it may involve lips, it may involve eyes, which is called as urticaria with angioedema. It may affect the larynx, and there may be suffocation. So one has to be very careful because these severe urticarias have to be treated as an emergency. And we can use injectable drugs in that, but majority of this, we find out the cause in acute urticaria, we remove the cause, and the urticaria would disappear. There are several causes for that, not only food, but food, medicine, sun rays, physical urticarias like pressure urticarias, heat urticarias, cold urticarias, immunological urticarias. Infections can cause urticarial rash. So there are several causes we have to find out. When urticaria lasts for more than 6 weeks, we call it as a chronic urticaria. And chronic urticaria is a very difficult thing to treat. The definition of treatment or success of treatment is not disappearance of urticaria altogether without medicines, but having no lesions with the least dose of whatever drug we are using is supposed to be a success. And we may have to use this for very, very long time. Like some patients of mine are controlled on low doses of antihistamines, say every alternate day or every third day, but they have been taking it for last 20, 30 years. In case of chronic urticaria, their tendency would be to use steroids or oral steroids, but we should refrain from doing that because they give excellent immediate results. But then patients may tend to continue that on their own. And we also may tend to give short bursts, but they require treatment for a very long time. We may have to do patch testings, we may have to do blood tests. Then we can do IgE level, serum IgE, because that would be raised, and then we may have to use some specific drugs for that. All these things are there. What I find is that instead of the tests which are done in the market, which are very costly, I ask the patients while on treatment to keep a diary that while they are controlled on treatment, if they get some kind of outburst in between, then they can just note down whatever they have done in previous 24 hours. And if they compare 2, 3, 4 times the lists that happen, whenever they got their urticaria, they can find out certain common things. And one of the interesting cases which I tell my patients, it is a detective's job, because one patient used to come to me with acute urticaria every September, October, or August, September, consecutively 3 to 4 years. And we were unable to find out the cause. And one day, suddenly in the 3rd or 4th year, we realized that she is coming always on the Ganpati days, or the day next to when Gauri Jevan Ghari hota. And she told me that she used to take out the sari, paithani of her mother-in-law only on the previous evening and used to wear the same thing on the same occasion every year. And as soon as she wore that, she would get an urticaria. And that was very interesting because you have to be a detective to find out what is the cause. Many times we don't find that, and we may have to use antihistamines for a very long time. The current dictum is you use a standard antihistamine, preferably non-sedating, like loratadine or desloratadine or cetirizine. Cetirizine, people say that it is a non-sedating, but many or most people would get sedation with that. Or depending upon the severity, we can go to Avil or Atarax or something like that if it is too disturbing. Fortunately, most of the antihistamines are extremely safe for prolonged use. And you try to find out the least dose that is most effective, and you can continue that for a very long time. So urticaria Hives are the common lesion. They can have sizes, varying sizes. Hives can be round, they can be rings, there can be red lesions or red flares at the borders, and they can occur anywhere on the body. Now, what is this? The lesions on the flexural part of the wrist. What we see is a reddish, slightly violaceous papulosquamous lesion, and we see whitish streaks on top of that. This is lichen planus. It can happen in the mouth. This is called as a mucosal lichen planus. The lines on the lesions are called Wickham striae. If we apply oil and see it under the lens, we can see these whitish lacy things. This is oral lichen planus. It is usually self-limiting thing, but it can run very chronic course, and it's extremely pruritic. The exact cause is not known, supposed to be immunological phenomenon. Histopathology or biopsy is very characteristic, in which we see basal cell degeneration, hydropic degeneration of the basal layer, and then pigment incontinence, melanin falling into the upper dermis, and we have a band-like lymphocytic infiltrate in the upper dermis. So it is very characteristic. What do we see here? Here again we see certain eczematous papules, nodules, or kind of things on the neck, excoriated marks. This is lichen simplex. As against lichen planus, this is caused by repeated scratching, and this happens usually on the neck or accessible areas. Like, for example, someone has a habit that someone is tense, he would start scratching like this, and then would get a lichenoid patch there. Or some people have a habit of scratching like this. Or some people would sit on the shin when they are sitting for study or work and are tense. Then they would keep on rubbing their feet or legs against a table or something like that. So this is caused by actually rubbing and scratching all the time. And what we see is a thickening of the skin at those places. Now, what do you see here? This is what we see is excoriated marks, but at places you would see tiny vesicles. Now, from papulosquamous lesions, we are going into vesiculobullous disorders. This is again an extremely pruritic condition. That's why it came in that sequence. You have excoriated lesions or vesicles which have burst open and forms crusts and scars. This is quite rare, but this is called as dermatitis herpetiformis. This is an immunological reaction. There is IgA in the dermal papillae if we do immunofluorescence. But this is rare, and we see very tiny vesicles like that. But here, what we see are large, tense bullae. Bullous lesions which are large and very tense. And if we press them, they don't spread around. This is called as bullous pemphigoid. This is usually a bullous disease of the elderly, so above 60, above 70. This is an immunological disease in which we have IgG antibodies against the basement membrane zone on immunofluorescence and subepidermal vesicular lesions on histopathology. Here you can see immunofluorescence, which is a basement membrane zone immunofluorescence on direct immunofluorescence. Of late, we have to keep it in mind that bullous pemphigoid somehow is becoming more and more common, and we are not able to fathom the causes why it is becoming more common. One thing could be that the life expectancy is increasing, so we are seeing a lot of older people now in the OPDs. That is one thing. But one of the most interesting things is the drugs which are used for diabetes, gliptins, and we have a host of them. Vildagliptin, sitagliptin, etc., etc. And these gliptins have got a tendency to lead to pemphigoid-like lesions. So bullous pemphigoid caused by gliptins. And when drugs cause pemphigoid, or for that matter, pemphigus. There are two types of that. One is drug-induced pemphigoid and drug-triggered pemphigoid. So drug-induced is if you find the drug which has caused that and you stop that drug, the disease will disappear. Whereas drug-triggered is the person had the tendency or had inclination to have pemphigoid sometime, and this drug has just triggered it. And in that case, they would require prolonged treatment. And the treatment of pemphigoid is usually oral steroids. They require smaller doses than pemphigus, say about 30 to 40 milligrams of prednisolone for a prolonged time. When it is milder, we can use doxycycline, we can use niacinamide or nicoglue-like drugs. Dapsone is one of the good drugs which is used for treatment of bullous pemphigoid. And of course, if it is severe, we have to use high doses of steroids or newer biologics like rituximab. In the same sequence, someone's mic is on and there is a disturbance. Can someone see that?
I muted her, sir.
Yeah, okay. So this is another of the papillus of the vesiculobullous diseases in which on the upper trunk, lower body, chest, scalp, and oral cavity, we would see superficial erosions. They start as vesicles, very superficial vesicles and bullous lesions. If you press them or if you press around them, you would be able to remove the skin from there. Bulla spread sign or Nikolsky's sign. This is pemphigus vulgaris. Okay, pemphigus vulgaris again is a disease, autoimmune disease, in which what we see is there are IgG antibodies against the intercellular desmosome. So the intercellular cementing substance would illuminate under immunofluorescence. This used to be a very deadly disease with very high mortality previously, but with the advent of steroids, the quality of life improved quite a lot. Survival became longer, but at the same time, very high doses of steroids for a very prolonged time, maybe years or decades, can have its own side effects. And therefore, we have to use alternative drugs or steroid sparing drugs. Steroid sparing drugs would be cyclophosphamide, azathioprine, mofetyl mycophenolate, and then some people are of late trying to use tofacitinib for that, for pemphigus. And I must tell you that one of the most important advent has been the biologic rituximab. And rituximab, in almost 70% of the cases, can take people off all medicines or oral steroids within a span of about 3 to 4 months and give excellent results. Somehow, why I don't know, but Dinanath Mangeshkar Hospital Dermatology Department has become a hub where pemphigus patients are coming from all over, and we are treating a lot of patients with rituximab in our center. Now, what could this be? This erythematous rash on the cheeks. This is butterfly rash. And if we see this, we have to ask for systemic features like fever, oral ulcerations, weakness, hair loss, etc., because this could be a feature of systemic lupus erythematosus. But this is also seen in patients who have got acne rosacea. Acne rosacea is a disease usually of the middle-aged people. They have acne-like rash, erythema on the face. This is associated with things that cause flushing. So it is very commonly seen in women around the menopausal time when they have flushes, hot flushes. Those who have got tendency to have acne previously can have rosacea. When they have lesions like this, they can get a swelling of the nose, which is called as rhinophyma, and which may require steroid treatment. But a common mistake done by people when they see erythematous rash on the face is treat it with steroids, which would cause immediate effect. But then there is a very famous book, very nice book of dermatology by Shelley and Shelley, and he writes very nice cryptic comments about several treatment modalities. And he says in his book, rosacea treated with steroids is rosacea treated with steroids, which means the cycle just perpetuates. You treat rosacea with steroids, steroids would cause rosacea. That rosacea you will treat with steroids and it will lead to further rosacea. So no use of steroids. In case of rosacea, we can use orally isotretinoin, minocycline, etc. We can topically use, again, just the same like acne. We can use antibiotics like clindamycin. We can use metronidazole topically. We can use ivermectin topically. Ivrea karke, there is a cream which is available. We can use that. But it's a chronic disease and it has to be treated properly. This I was talking about. Like you see a rash on the malar area, you have to look at rash at anywhere, any other sites in the body. The person may have rheumatism or bone pains, generalized weakness, etc. But we are not going to go into these diseases which are connective tissue disorders, but this can be a feature of SLE, systemic lupus erythematosus. Okay. So now what do we see here? This is common, you see almost daily. There are crusted lesions, there are excoriated lesions, there are superficial multiple ulcerations which are grouped. And on the other side, we see multiple localized vesicular lesions. Okay. So the description of grouped vesicular lesions is called as herpetic or herpetiform. We saw dermatitis herpetiformis. This is herpes simplex. जर म्हणतात मराठीमध्ये तशा अर्थाने. This is the HSV1, HSV2. There are two types. One causes generally the lip lesions. HSV2 causes usually the genital lesions. That is sexually transmitted. But what we see is recurrent grouped vesicular lesions. There are several, 7 or 8 viruses in the herpes virus family. Herpes simplex virus, varicella zoster virus, cytomegalovirus, Epstein-Barr virus, etc., etc. And the common feature of a herpes group of viruses is that they always have a primary infection, and once there is a primary infection, the virus stays in the body forever. And there are recurrences when there are blips in the immunity. So whenever your immunity goes down, the virus is going to come up. And majority of these infections like recurrent herpes simplex, herpes zoster, or CMV retinitis in immune compromised patients, or Epstein-Barr virus infections in immune compromised patients are all reactivation of the latent virus. And so we have to take care of these infections, primary infections. This is herpes simplex. This is herpes simplex virus. And this is another one, that is a varicella zoster virus. In the childhood, this would cause chickenpox. The virus would stay in the body, and when your immunity goes down, the virus that is staying in the dorsal root ganglion of the nerves would get reactivated, and you would always get lesions in the dermatomal fashion. So herpes zoster ophthalmicus, or on the chest, or on the legs, or on upper limbs, it would be always unilateral. Almost always, I must say. When the immunity is too low, one can also get bilateral lesions, but that is very, very rare. And as I mentioned, the treatment of herpes simplex is also acyclovir, valcyclovir, etc., but the dose is low, 400 milligrams 3 times a day. Whereas in case of varicella and herpes zoster, the dose of acyclovir is very high. If we use acyclovir, it is 800 milligrams 5 times a day. Alternatively, we can use valacyclovir 1 gram 3 times a day. It becomes more convenient. And here is only one point I'm going to talk about HIV, is that you must screen all patients of recurrent herpes simplex as well as herpes zoster, irrespective of age, gender, religion, status in the family, socioeconomic status, etc., for at least 3 things. One is anemia, second is diabetes, and third is HIV. because you would pick up a lot many people earlier, because reactivation herpes zoster is a very common feature of HIV disease. What do you see in this child? We see a lot of crusted lesions, erythematous lesions on the face. Okay. The similar lesions are there on the around the lips, crusted lesions. This is called as a golden honey-colored crust with stuck-on appearance. झाडाला आपण डिंक बघतो कधी कधी, काही झाडांना डिंक असतो, तो असा चिकटलेला असतो, स्टक ऑन अपीयरन्स. These are the crusts which are stuck on. Golden yellow or honey colored crust. This is impetigo. Impetigo contagiosa, very common in children. This is usually streptococcal but can be staphylococcal. And we can treat it if it is localized with topical antibiotics, or we use systemic antibiotics for impetigo. What we see is generalized erythematous rash all over the body, almost all over the body. This you must be seeing measles. Okay, it's very, there are coplic spots in the oral cavity also, and it's interesting to find that the rash is called morbilliform. And what is morbilliform is measles-like rash. So a measles-like rash is morbilliform, and morbilliform rash is a measles-like rash. That's a funny name, nomenclature. We have said this also. Similar erythematous rash, that is rubella. What we see here is vesicular rash. And if we see closely, there is erythema around, and there is a central vesicle. This is called as dewdrop on a rose petal formation. Like on the rose petal, there is a dewdrop. So there is erythema around and there are vesicles inside. And this is usually seen on the central body. This is chicken pox. We have already talked about the treatment. Let's go to the other conditions. What we see here is the localized loss of hair. What is this? And on the other side, what we see is not a very classical one, but there are broken hair around. Not complete loss of hair, but broken hair. So these are called alopecias. The one which is complete loss of hair is alopecia areata. The other may be a part of a disease called as trichotillomania. Trichotillomania is many people have got this habit of plucking their hair when they become stressed. And there we will see a slightly broken hair around. And the thing is that they won't accept that they are plucking or breaking their hair. But I tell them that this is probably happening unknowingly. So तुमचे आधी हात तरी बांधा either किंवा डोकं तरी बांधा. Don't allow your hand to touch your head and you will get the regrowth of hair. Alopecia areata is supposed to be an autoimmune condition where there would be lymphocytes and around the hair follicles, and they are not allowing the hair follicle to grow. So the treatment of alopecia areata would be topical steroids, intralesional steroids. Nowadays we use a lot of tacrolimus or pimecrolimus topically. There are new lasers which are called excimer lasers. They have excellent benefit in alopecia areata. Alopecia areata, when localized, it is called areata. If it is all over the scalp, it is called as alopecia totalis. When it is all over the body, all hair from the body are going away, it is called as alopecia universalis. It is a cosmetically disfiguring disease, and nowadays we use biologics or tofacitinib or intermittent pulse steroids for treatment of these diseases. This is very simple. What we see is not hypopigmentation, but completely depigmented macules. And this is vitiligo. Okay. Vitiligo again has got a lot of social stigma in our country or many countries. It's an autoimmune condition where there are antibodies against the melanocytes and they are destroyed because of your autoimmunity. There are several modalities which can be used to actually treat vitiligo. Previously, we used to use potent steroids. Now it is funny because one of the commonest side effects of potent topical steroids applied locally would be depigmentation. And here we use topical potent steroids for treatment of localized vitiligo. We can use tacrolimus, we can use pimecrolimus, we can use topical melanocyl or Sorlens applied and then exposed to ultraviolet rays, either in the chambers or to the sun rays. We can use narrowband UVB treatment, which is not available, that UVB is not available from the sun. So we can ask the patient to go to the chambers and use narrowband UVB. And again, of late, we have been using a lot of immune suppressants like azathioprine, methotrexate, or even tofacitinib to treat vitiligo. And we have around 70 to 80% good results in majority of the cases. There are certain things which need to be talked about vitiligo. It is a bit of a disease which has got a hereditary tendency, but it is not 1:1. That one who does not have vitiligo in the family is not certain that he will never get vitiligo. And those who have vitiligo in the family does not mean that the progeny will always have it. And this question keeps on coming, especially regarding the marriages. And the common advice I give is, if basically it's not a disease, if the person likes someone with a vitiligo, there is no problem in having marriage with someone, because it is not going to affect the other functions of being friends and kind of being together. On the other hand, if you don't want to marry someone who has got vitiligo, but there is a family history in someone's family, then at most you can do is you just get it checked from someone and ensure that there is no vitiligo as on day. Because once there is no leukoderma lesion on a particular day, both the partners are almost more or less same likely to have may get vitiligo in future. So it is not that someone who has a family history has slightly higher chances of getting vitiligo, but it does not mean that one who does not have the history will never get vitiligo. So you have to be very cautious in counseling these patients. But many times doctors themselves tend to tell people that kashala त्यांच्या घरामध्ये कोड आहे, त्यांच्या घरामध्ये काही लग्न विग्न करू नका. I think it's a way of not good counseling, because we as dermatologists have been trying a lot every year to reduce the stigma against vitiligo, but somehow we should not at least tend to perpetuate that. What we see in these children is only small, recurrent, evanescent, hypopigmented plaques. These are not depigmented. These are associated many times with nutritional deficiency. This is called pityriasis alba. We used to deworm these children. We used to give these children iron, calcium, etc. But it keeps on coming and going. And then topically, if we do a biopsy, we see a very marginal eczematous changes. And the treatment of choice would be nowadays tacrolimus or very mild steroids. Okay, not potent steroids, because otherwise they would increase the hypopigmentation. Now, how do we describe this lesion? There are erythematous lesions, slightly plaque-like spread lesions, but what we see is lesions which are called as satellite lesions. And especially these satellite lesions, if they are pustular, we are definite that this is a candidial infection. This is candidial intertrigo. Okay. And if we do a KOH smear, we would see candida there, budding yeasts there. Okay. That's a fungal infection. And we'll have to treat it with either topical antifungals. Azoles are better, as I said. With respect to this budding yeast, Malassezia furfur. So similarly, here azoles are better than other. Griseofulvin, of course, does not work, and it should not be used. Fluconazole, ketoconazole, itraconazole help. Topically, we can use azoles. Candidal vaginitis, you can try a couple of times with topical azoles, but if it is recurrent, then you have to use systemic systemic antifungals. All cases, especially middle-aged people with candidal balanitis or balanoposthitis, or women with candidal vulvovaginitis should get screened for diabetes, because that is the commonest association with candidal lesions. How will you describe this lesion? So this is a small papillar lesions or papillonodular lesions with annular distribution. I am just showing this because fungal infections also have annular lesions, and this is showing annular distribution or annular morphology, and this is called as granuloma annulare. This many times happens with solar exposure, solar elastosis, etc., and requires topical steroids or intralesional steroids or other drugs like isotretinoin. What is this? Again, an annular lesion with scaling, with some probably pustular-like lesions. This is on the neck, this is behind the ear, this is scaly lesion, annular lesion. On the face, this is again active margin and active border with scaly lesion in the groins. This is on the thighs and in the groins. This is on the buttocks. This is on the face. And this I am showing more because nowadays you must be seeing at least 10 cases in your OPD every day of tinea infections of various things, various sites. So it could be capitis, facie, corporis, cruris, manum is hands, pedis is feet, and nails, that is onychomycosis. This picture is more common than the classical pictures I showed before. What we see here is multiple rings. It is spreading some places, it is going some places, and the first question we will ask this patient is, what cream have you applied? Okay, and this is again extensive lesions with central clearing. It is just keeping on spreading on all the ends. Here we see large plaques without any central clearing. Here we see papules, and the ring is not uniform, it is disturbed. So, and if we ask this question, which cream have you used, they would generally tell one of the names. Okay. Okay. So these are combinations or plain steroids because they control each rapidly, and therefore the simple suggestion to my patients is any cream that has got more than 2 names should not be used. Any cream that has got a number in the cream, 4-derm, Dermi 5, etc., should not be used because these are called as tinea incognito. These are the things like, combinations, low-bed GM, Candid B, Quadriderm, etc. These should not be used completely. No combinations for antifungal treatment. You can use clotrimazole, miconazole, any terbinafine, sertaconazole, iverconazole, amrolfin, laliconazole. Newer topical antibiotics are coming almost every year. You can use them, and you can use, depending upon the fungus, griseofulvin, fluconazole, terbinafine, ketoconazole, itraconazole, or voriconazole. I won't suggest you use voriconazole for superficial fungal infections. It should be reserved for systemic infections. This is very common in diabetics. These are erythematous shiny plaques. These are seen in diabetics. This is called necrobiasis lipoidica diabeticorum. And this can be treated again with topical steroids or tacrolimus, or may require systemic treatment. What are these? These are erythematous nodular lesions on lower limbs. We see in both the cases, we see this erythema and nodular lesions. Painful nodular lesions on the legs, which tend to resolve, leaving behind hyperpigmentation, is erythema nodosum. And erythema nodosum can be acute most often it is associated with something like a streptococcal throat infection. But chronic recurrent erythema nodosum is a very troublesome disease. We may have to do biopsy to prove that. If it shows granulomas, it could be associated with tuberculosis. But any systemic infection or a systemic disease can cause erythema nodosum. And there could be several causes for that. Drugs, diseases like tuberculosis, mycoplasma, connective tissue disorders like systemic lupus erythematosus, all can cause erythema nodosum, and they have to be treated properly after doing a lot of investigations. Here we see a ring-like lesion with a central vesiculation. The vesiculation may not be there, just discoloration could be there. This has to be differentiated from that dewdrop on the rose petal kind of a thing. This is what is called as a target lesion or iris lesion. For shooting, they use these targets with concentric rings. These are concentric rings with edema, erythema, and vesicle. And this is called target lesion. This is erythema multiforme. Erythema multiforme classically is called as erythema multiforme minor, erythema multiforme major. If it is extensive, it is called Stevens-Johnson syndrome, and it has got an overlap with what we call as toxic epidermal necrolysis, where extensive lesions or lesions like extensive burns are seen on the body. But common thing which you would see erythema multiforme, which is recurrent, is almost always associated with herpes simplex infection. Herpes simplex infection triggers erythema multiforme. But the other causes of extensive erythema multiforme or Stevens-Johnson syndrome would be drugs, infections, and other diseases. Of late, again, herpes zoster or erythema multiforme or erythema nodosum have become more common in last 2 to 3 years. Many people got these after an attack of COVID-19, or many people got it after getting their doses for COVID vaccine. So they were triggered by certain things, and this can happen with multiple causative factors. What we see here is a volcano-like lesion. It's a nodular lesion with central volcano-like thing. And this is a localized keratoacanthoma. Many people believe that this is a non-spreading squamous cell carcinoma or precursor of that. So why we are now going into nodular lesions, and we have to be careful because these have to be biopsied and these have to be treated accordingly. Here you would see a lesion which is a horn-like lesion, but it has bled a lot. Okay. And there is a stalk-like thing. And here again, there is a blood-filled lesion on the lip. These are called as pyogenic granulomas, which are vascular structure, angioma-like structures, and these have to be cauterized. They cannot be treated with medications. These are very dramatic kind of a thing. In the scalp, there is a small lesion, bleeding lesion, and while combing, suddenly it starts bleeding profusely. Recently, we saw some granuloma pyogenicum at the tip of the finger, and someone was treating it like burn, feeling that it is or something like a pinch or in the door or something. But it just bled profusely one night, and we had to cauterize that. What do we see here is the superficial scaly lesions on sun-exposed areas. Okay, so these are called as solar keratosis. Solar keratosis are supposed to be pre-malignant. They happen in sun-exposed areas, especially in non-pigmented people. They are rough. Okay, we can do liquid nitrogen cryo surgery on that and treat them. The differential diagnosis of this would be seborrheic keratosis, which are hyperpigmented scaly lesions seen in elderly people on face, scalp, etc. And they are very benign conditions. They are not pre-malignant conditions. So we have to differentiate between these. What we see is a indolent, slowly growing nodular lesion, especially around the margins of nose or margins of eyes. Sometimes they can be just small lesions with a lot of crusting there with a pigmentation at one end. Here we see a plaque-like thing spreading its tentacles around. What is this? This is a basal cell carcinoma. And again, because the population is aging gradually, we are seeing more and more of basal cell epitheliomas in the elderly. Fortunately, basal cell carcinoma or basal cell epithelioma is usually a locally spreading disease, and it usually does not metastasize. And therefore, wide local excision or treatment with cryotherapy or 5-fluorouracil also can sometimes help treating basal cell epitheliomas. But sometimes the lesion can start like this, and sometimes the lesion can be like this on the lips, especially in people who are habitual of chewing tobacco, smokers, etc. And this is squamous cell carcinoma. It's less common in Indian population, but it is definitely increasing again. Persistent scaly patches, not usually pigmented, maybe nodular. This can metastasize and has to be excised. Not only excised, may require radiation therapy, etc. This is even more rare in Indian populations, but again, we have started seeing a few cases. Like, I'm not saying the incidence has increased, but if we have seen about 10 cases in first 20-25 years of my practice, we have seen about 4 or 5 cases in last 3 or 4 years. So what we have is this pigmented lesions on the extremities, could be under the nails, could be on the face. But what you see here is that it is not uniformly pigmented. At one place it is reddish, on other side it is blackish, and it is going inside. It can be like this, very dark. It can be under the nails. Melanoma, as I said, incidence is increasing. There many times is family history. It is seen more amongst fair-skinned people, legs in women, back in men, history of burning or blistering. How do we suspect that? If there is any asymmetry in the pigmented lesion, there is differential pigmentation across the lesion. It has recently changed in shape or color or size. It is bleeding on touch or started itching and has started showing satellite lesions. We should suspect melanomas. These are deadly diseases, deadly melanomas. If detected early and excised, then only we get good results. This is again very common thing which you must be seeing in your practice. And I'm coming to the end of my presentation. This is melasma. Okay, pigmentation on the cheeks. There are several modalities that are available, like azelaic acid, like kojic acid, and now newer products are available. You can use them at night. You can ask the people to have sunscreen in the morning. But we have lasers also, Q-switch lasers also. So topical, we can use hydroquinone, kojic acid, glycolic acid, tranexamic acid, etc. We can use sunscreens. We can use orally vitamin C, tranexamic acid. But we should be beware of these things, because majority of the people would have applied some steroid combination, and that leads to this. This is called topical steroid damaged face, TSDF. And so don't use steroids for that. Not only that bad, but sometimes it can cause atrophy, etc. So don't use these combinations. It can cause hypertrichosis. It can cause tinea on the face, tinea incognito. So this is topical steroid damaged face. Please don't use these for any steroid, fungal or melasma or anything. So thank you. Brief presentation, brief run through several diseases. And now questions, if you have time, or otherwise we will call it off.
Yes, sir, we have time. Dr.
Thank you so
Gayatri?
much, sir, for
Yes.
this wonderful session. And I'm sure the knowledge that you have shared with us today will be very useful for all of us in our day-to-day practice. And there are a few questions. I will start with the questions, sir. Is pityriasis rosea a fungal or viral infection?
Pityriasis rosea is a viral infection. Did I say fungal? No, I think.
There was a question in the
Yeah,
chat
yeah,
box.
okay. Okay.
Can we use terbinafine, fluconazole, itraconazole in pediatric patients, and for how many days, and what should be the dose?
Terbinafine, not in very young children below 2 or 3 years. Itraconazole, the fluconazole would be the safest drug because we use it in children with candidial infections. But if pushed to the wall, we can use anything. But we would like to avoid ketoconazole, itraconazole in children. Fluconazole would be a safer drug for systemic treatment.
Okay, so for how many days can we use it?
We can use for 2 to 3 weeks also, no problem.
Okay. And dose?
It would be weight dependent, but I would tell you a standard thing. Instead of calculating thing, you take 50 milligrams tablet, which is a dispersible tablet. For children less than say 4 years or something, you use half the tablets. Above that, you use 50 milligrams every day. As the weight band goes to 30 kg or so, you start using about 100 milligrams. Above that, 150 milligrams.
Okay, thank you, sir. If IgE level is raised, then what is the treatment for that?
If IgE levels are very high, then we may use a biologic called omalizumab, which is an anti-IgE antibody biologic. So it helps in atopic dermatitis, extensive IgE disease or IgE raised lesion. When we see serum levels of IgE are raised, it is one of the good drugs to use that, because then we have a specific targeted drug available for that. But all our atopics would generally have raised IgE levels. So this is very high. All patients with all allergic dermatitis also may have IgE levels because it determines the allergic status. And in that, we need not use always the omalizumab, but we can use, say, for example, short bursts of systemic steroids, or we can use other immune suppressants like azathioprine, methotrexate, all these mycophenolate mofetil. All these drugs are very nice drugs. We can use them.
What is the role of histoglobulin injections in chronic idiopathic urticaria?
According to me, none. Zero.
Okay. So it should not be used.
Yeah.
Okay. What is the treatment of lichen planus?
Lichen planus, if it is localized, we can use potent steroids. If it is acute eruptive lichen planus, we can give a short course of systemic steroids because it brings it down very rapidly. If it is a chronic recurrent hypertrophic lichen planus, which is not responding to our first line of treatment, then we would like to avoid systemic steroids and use drugs like methotrexate, cyclosporin, azathioprine, etc.
In post-herpetic skin lesions, if after it gets better, even after that there is pain or itching, then how should we treat it?
This post-herpetic neuralgia I skipped because it did not have any skin lesions, but we have around 10 to 15% of patients with herpes zoster who have this very severe debilitating post-herpetic neuralgia. And it is to be treated as per the severity. If it is only a pain or intermittent pain, you can use just simple paracetamol. If it is more than that, you can use something like, say, gabapentin or pregabalin or tryptomer or something like that. And if it is still not getting under control, we have to use sometimes these surgical procedures for nerve decompression or desensitization kind of a thing. So it all depends on that. But this debilitating post-herpetic neuralgia is a disease which is a nightmare for a patient as well as for the doctor.
So I have seen some people using steroid for that. Is it useful?
I don't think so. Chronic post-herpetic neuralgia, steroids have no role because it is not that kind of an inflammation. Many people believe that steroids given in the early stage of herpes zoster along with antivirals reduces the chances of post-herpetic neuralgia, but that is also suspicious. Acyclovir, valcyclovir started early in the phase of herpes zoster. Within first 48 hours, definitely reduces the chances of post-herpetic neuralgia. And of late, many of you might have been approached by people from Glaxo because they are going to soon launch a vaccine against herpes zoster, Shinglix or something, and they are recommending it above 50 because herpes zoster becomes common after that. We are not very sure whether it reduces the chances of herpes zoster or whether it really reduces post-herpetic neuralgia. Data are very nice. Unfortunately, the cost of 2 doses of that is around 20,000 rupees, and I'm not very happy with the cost of that vaccine.
Yes. What is the difference between moisturizers and emollients?
Emollient would be, I would say it is emollient is only an oily kind of a substance which actually puts kind of a oily layer on the surface of skin. Okay. Moisturizers have combinations of several things. It does have emollients. It does have things which repairs the damaged cuticle. It does have surfactants, and it's a combination of several things. So all the kind of things which are required for dry skin would be there in moisturizers, but definitely moisturizers are costlier. And emollients for a routine. So for example, आता थंडीमध्ये पाय फुटायला लागले. You don't require a moisturizer. You just wash your feet, don't apply soap, and while they are wet, you can just apply a plain simple oil on that, and it works like an emollient. So,
Yes. What is the treatment of epidermolysis bullosa simplex?
epidermolysis bullosa simplex, actually, there are no specific treatments as such. Some people have used some drugs experimentally, but there is no definitive treatment. Simplex is less troublesome. Epidermolysis bullosa is a problematic thing when it is chronic and is causing scarring. And there are no definitive treatments for that. Some people are using antihypertensives in that, but there is not consensus on that. And they usually don't have any treatment for that. It's a congenital disease, mechanobullous disease, where there would be blisters after friction.
What is the treatment for multiple keloid?
Oh, keloids again is a very difficult thing to treat. If there is a discomfort because of that or disfigurement because of that, we can do intralesional steroids. We can use some of the lasers along with intralesional steroids. We can use 5-fluorouracil injectable in the keloids. If pushed to the wall, sometimes people do is, if it's a resizable kind of a thing, do excision, and while suturing, inject steroids in the suture line and then give a or rather compressing kind of a bandage for that, so that it doesn't get stretched and you don't get a keloid again at that place. But there's no definitive treatment.
Is it necessary to deworm every skin patient?
No, I don't think so. But it could be good that we deworm everybody in our country, because it would at least help anemia.
Yes, sir. Which moisturizer is good in case of dry skin, and what is the role of vitamin A in dry skin?
Unless there is a vitamin A deficiency, it's a kind of a thing that vitamin A leads to health of the skin. We don't use oral or treat every patient with dry skin with vitamin A. But if you have those follicular lesions like phrinoderma, which are definitely like vitamin A deficiency, then they are going to respond to vitamin A. That is one thing. Secondly, as I just now explained, for just routine dry skin, you don't require anything. You just require application of some emollient or oil on wet skin. But if it is more severe, then we use whatever that is available as moisturizers with increasing cost and increasing efficacy.
Yes. What is the treatment for stretch marks?
Exercise. Reducing your muscle tone, because there is hardly anything that can be done for stretch marks. So you increase your muscle tone or the tone of the muscles underneath, and the stretch marks will disappear. But again, nowadays, many people would use fractional CO2 lasers, etc., to treat that. And I don't think there is anything specific for stretch marks.
Yes. What is the treatment for recurrent scabies?
Recurrent treatment for scabies. So the treatment remains the same, because recurrent is one thing is you will have to use the same permethrin, gamma-benzyl hexachloride, etc., ivermectin. But if it is recurrent, it means the source is there is some source which is causing it again and again. And there can be two sources. One is human scabies, or there could be animal scabies, which is sometimes missed because no one in the family is suffering from that. You feel there is no one, but someone is getting scabies many times, recurrent scabies, and it could be a contact with some pet at home, a cat or a dog or something like that. So you will have to try to find out the source. For example, people living in hostels, or if some roommate or the fomites have got scabies and only you go to the doctor and come back after treatment, you are bound to get it again. So it is not a person is getting it recurrent. It is generally not the person is failing treatment. It is usually a source is there which is causing recurrent scabies.
Right. What is the line of treatment for tinea, especially which has been previously treated with steroid?
First is to stop the use of steroids. Tell the patient that there is going to be an exacerbation. There are going to be exaggerated symptoms, and is going to require a very, very prolonged treatment. My first drug of choice to go is itraconazole. But people use terbinafine also, and nowadays we may sometimes require combination. So itraconazole with griseofulvin, terbinafine with griseofulvin, terbinafine with itraconazole. But some people require, they respond well, but they require treatment for 2 months, 3 months, etc. It's a very costly affair. And many people in the families have now familial tinea kind of a thing, 4 or 5 members in the family having recurrent tinea treated with steroids and kind of things. And it becomes a horrible thing because itraconazole also is not a cheap drug. You require about 200 milligrams per day. And it would be about 40 rupees a day for a person, a single person, and then whole family requiring that for 2 to 3 months becomes a huge expense for many people. But again, we have to tell these people, just like scabies, that dry clothes, cotton clothes, no synthetic undergarments. See that you don't sweat a lot. In rainy season, see that your undergarments are dry. Don't use wet garments. Change your wet clothes. Test for diabetes. And one of the very common suggestion I give my people is, many people say, I don't have diabetes, but they are drinking 6 cups of tea with sugar during the day. That makes it about 20-24 teaspoons full of sugar during the day. Obesity reduction, weight reduction, avoiding friction, all these things have to be told to the patient to avoid recurrent fungal infections.
Yes. Can alopecia be a result of fungal infection?
Yeah, I did not go into the differential diagnosis of alopecia as such, because there are several reasons. Fungal infection could be there. There could be psychological things. There could be immunological things. There could be lichen planus causing alopecia. So generally alopecias are scarring alopecias, non-scarring alopecias. Non-scarring alopecias, the things start from alopecia areata, fungal infection, etc. Whereas scarring alopecias would be SLE, DLE, lichen planus, immunological causes, etc. And then that has to be differentiated and treated differently.
Is there any specific ointment for psoriasis?
No specific ointment. I explained keratolytics, ureas, steroids, calcipotriol, tacrolimus, all this can be used, but there is nothing specific for that.
In dermography, then, what is the treatment?
Dermographism is a type of urticaria. That's why I combined it with urticaria. The way you treat urticaria, dermographism is to be treated just like that.
It's already 5:15, so there are a few more questions, but I think we should stop here, sir. Is it okay?
I think Dr. Gayatri, 1-2 question. Granuloma annularis.
Okay. What is the medicinal treatment for that?
We use doxycycline sometimes, we use antibiotics, we use isotretinoin for that, acitretin for that. I just showed, but for want of time, I did not go into the differential diagnosis of that. But annular plaque-like lesions, we will have to have a differential diagnosis of, say, granuloma annulare, leprosy, and other kind of thing, sarcoidosis, etc. for that. But because we had lost about 5 to 10 minutes, I did not discuss that. But it will have to be proven that it is granuloma annulare. It is not any other granulomatous disease or plaque-like disease. It could be sometimes even cutaneous T-cell lymphoma-like plaques. B-cell lymphomas can cause similar kind of plaques. So it will have to be treated accordingly after diagnosis.
And what is the dose of isotretinoin?
Oh, books would say 1 to 2 milligram per kilogram is the standard dose, and tablets available are 5, 10, 20, and sometimes 40. But I have rarely used in our patients more than 5 milligrams.
Okay.
It causes severe dryness of lips and eyes if higher doses are used. And especially if the higher doses are combined in treatment of acne with drugs like minocycline or doxycycline, theoretically, there is a risk of pseudo tumor cerebri, like headache and loss of vision, etc. It can be a very serious complication. So you have to tell patients that if you start getting something like that, you have to stop that. But I have hardly ever used more than 5 milligrams.
And what is the
Maybe
treatment?
we can just quickly one line, one word kind of answer, so that people should not feel की त्यांचे questions घेतले नाही. एक 3-4 प्रश्न असे सर घेऊ शकू चालेल?
Oh, rapid fire.
Rapid fire मध्ये थोडंसं, so that people will just get quick answers. Yeah.
Treatment for pityriasis alba.
Tacrolimus.
Can skin diseases be caused by intestinal parasites?
What can be caused?
In skin diseases be caused because of intestinal parasites.
Sometimes urticarias can be because of the parasites, but not necessarily something which is very specific that this is because of these things. Or unless there are intestinal parasites which larvae go into the skin, which is called as larva migrans, that is a directly related kind of a disease. But otherwise, no.
Okay, that's all.
Gayatri, did we take this one question? Dermography.
Yeah, we did that.
Yeah,
we did
आणि
that.
एक दोन क्वेश्चन, एक क्वेश्चन YouTube वरती आहे, विटामिन डेफिशियन्सी अँड कॉमन स्किन प्रेझेंटेशन.
Okay, so the commonest thing, vitamin deficiency kind of a thing we see is multivitamin deficiency would be dry skin, overall weakness, etc. But the best association what we see is pellagra. Okay, niacinamide deficiency, and which is very common in alcoholics. So, but otherwise we will see like scurvy-like thing in vitamin C, then other things with vitamin B deficiency, angular cheilitis, etc. But they are common, you know that.
Yes, sir. So with this, I think we have come towards the end part of this nice, informative, knowledge-sharing webinar. I'm supposed to summarize what Dr. Vinay Kulkarni sir has said, but already I'm sure Saranni Purna Skin's Pustak, he has tried to really make it compiled and compact into this 1 hour session. So there is very limited, मतलब मैं उसको summarize करने के लिए मैं कुछ बोल ही नहीं सकती honestly. Only for the people who may not know, in the beginning of Muktaa Charitable Foundation, for me and Dr. Madhu Oswal, we were during internship sir's student, and sir's dermatology OPD, dermatology, skin disease, venereal diseases, and HIV OPD, that made us think about working in field of HIV. That was the motivating reason for us to start working in the field of HIV. So he has been our teacher, but without making us feel like being the teacher, more like a friend, a guide, a support system, and all those kind of, the resource where we can always very easily approach for not, and it's not just about me, I'm saying, it is about Muktaa that I'm saying. Like all these years, डॉक्टर विनय कुलकर्णी, संजीवनी कुलकर्णी सरांच्या बेटर हाफ आणि प्रयास ऑर्गनायझेशन हॅज बीन शेअरिंग अ व्हेरी कॉर्डियल रिलेशन ऑफ knowledge sharing with Muktaa Charitable Foundation. No words of thank you.
बस 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 आपल्याला उशीर होतोय.
Yes, so sir, thank you once again for being with us, and we really look for such opportunities every now and then for
Yeah,
this
welcome.
learning from
Welcome
you.
anytime.
Thank you.
Thank you.
Sir. Yes. So I'll end the meeting. Yes. Thanks. Thank you everyone for
Thank
being
you,
part
sir.
of this learning.
Thank
Thank you so
you.
much, sir.
There 100
you.
लोक Zoom वरती 100 and there were some 47 people on YouTube.
YouTube. Yes.
तो सुद्धा थोडासा कन्फ्युजन झाला जरासा म्हणजे युट्यूब लिंक मला सेशन चालू असताना तयार करायला थोडा टाइम लागला टेक्निकल ग्लिच मुळे.
आणि मध्ये थोडा ब्रेक झाला म्हणून अदरवाइज
थोडस हा.
Thank you.
Yes, sir.
Thank you, sir.
Thank you.
Yes, wonderful session.
Yes. Thank you everyone.